Good afternoon and welcome to this month's session of Ask the MS Nurse. My name is Cherie Binns. I'm the Patient Healthcare Liaison for the Multiple Sclerosis Foundation. I'm an MS certified nurse and have been for more than 20 years, and I've also been living with MS, diagnosed 30 years ago, but symptomatic for nearly 20 years prior to the diagnosis. So I've kind of learned a lot the hard way. And my mission is to kind of share some of those experiences combined with the science of MS treatment to help you on your journey. So if you're joining us on Zoom today and you have a question about symptom management or how to make the most of your doctor's visit, please type it into the Q&A. The chat will predominantly be for giving you resources if something is shared that we want you to be able to have. We're also live streaming on Facebook, so you can type your questions into the comment section on Facebook, and Bhavya, who is behind the scenes with me, will be forwarding those questions. I don't see any questions in either the chat or the Q&A yet, so I'd like to kind of bring one thing to the fore. This week in our main Facebook page, we have several private Facebook pages as well as our public facing page. Our large private Facebook page, the Multiple Sclerosis Foundation private page, has about 25,000 members on it. It's a community that is people living with MS or maybe their significant others, people who think they might have MS, gathering information for it, and even maybe students that are looking to find out how MS impacts people. And there's been a number of questions in the last week or two about people really feeling like rather than managing the MS, they had to get other comorbidities, or what we call comorbidities, other conditions, under wraps or under control. And the things that were mentioned were things like diabetes and high blood pressure, hypertension, maybe obesity, renal disease, kidney disease. So all of those things, any comorbidity that you have that is not well managed can make your MS symptoms worse and can make MS itself harder to control. So I would encourage you to not kind of keep everything in a box, but to treat the whole person, the whole picture, so that everything that's going on is well managed. I have a question from Benita who says, my name is Benita. I've been diagnosed with MS in 2021. I have trigeminal neuralgia and it might be bilateral. They're saying that the MS has caused it and the pain is unbearable. I'm now on ketamine, just need guidance, and if there's any other ways to dull the pain. There are other ways to dull the pain. However, in my experience, they tend to make me fuzzy-headed. I had a 3-year period with trigeminal neuralgia where I just couldn't do anything to get it under control, and the medication that I was being given is from the anti-seizure medication group of meds. It just made my head fuzzy, and I was sleepier than usual and didn't manage it well. What I found really kind of helped, there are a couple of things that I found helped. One of them was alternating heat and ice over the area, and for a while it was so tender I couldn't even touch it. So I kind of had to hold the cool or the warm near my face, but not actually touch my face. So that may help. I found that if I was chewing anything of substance, that it seemed to make the pain worse. And so a softer diet seemed to help. So those are a couple of things, Benita, that you might try to deal with some of that discomfort. Janice says, foot drop, what causes it? And can you improve foot drop with exercise, or is the damage done and you have to live with it? Janice, foot drop is caused by a disconnect with the nerves going to your leg. That often can be helped by strengthening other muscles in the area to keep you from tripping on your foot. Uh, a physical therapist can certainly help you with that. And I've had very good luck with that. There are a number of other things that you can get to help with the foot drop. There's a product called Foot Flexor. That's Flexr. If you search that in your search engine, it's basically a band that velcros around your ankle, and then it has a 1 inch wide long webbing that you hook into the eyelets, or hook around the grommet of the end of your uh, tie up shoe, and then you tighten it to keep your foot from flopping down. They're about $30 for a pair of two. And I found that if the foot drop is not really severe, that's been very, very helpful with me. I would not recommend that you get an ankle foot orthotic, or AFO, without seeing a physical therapist and getting something custom made for you. You can buy them on Amazon and on medical supply companies, but they're not fit to you personally and can cause some blistering possibly, or rubbing, that can cause some discomfort. So I would not buy something over the counter like that without having it personally fit to you. Um, Benita says, yes, it made me very sick and depressed talking about the trigeminal neuralgia. Troy says, I've been diagnosed with primary progressive MS, but I'm awaiting treatment. I'm struggling to walk and other symptoms. Is there anything I can do for myself while I wait for treatment to feel better? I've been dieting and other things. With primary progressive MS, we don't generally expect to see those symptoms get better. We do, however, with treatment, and the only treatment for primary progressive MS at the moment is OKRIS. We do expect with most people to see either a slowing of decline, or a stopping of that decline altogether. So in 1/3 of people right now that are taking OKRIS that have primary progressive MS, we're seeing no further deterioration in symptoms at all. Uh, with those people who have relapsing forms of MS, in 8 out of 10, 85% of people actually are not seeing any progression after 5 years of taking OKRIS. So it does halt the progression. Troy, one of the things that you might do, kind of to both increase your energy level and maybe clarify your thinking, decrease fatigue, would be to cut out all sugar in your diet that is refined sugar. In other words, the sugars that naturally occur in foods such as your fruits and vegetables are fine. But anything that has a sugar in it, a processed sugar, including things like ice cream, or uh, any sort of dessert, pie, cake, cookies, um, even things like spaghetti sauce are very rich in refined sugars. So you might want to reduce those or cut them out altogether. That can often help to slow this down. Um, let's see. An anonymous attendee says, concerns with any DMT. For those of you that don't know what DMT is, that's disease modifying therapy. I've been diagnosed about 1 year ago, and I'm kind of afraid to take meds outside of muscle relaxers. Thoughts? How about thyroid? Um, you can treat, as I mentioned earlier, you can treat other conditions, and we encourage you to hop on anything that might be a problem, such as thyroid disease. or high blood pressure or diabetes. Those all need to be kept under control to keep your MS at bay. However, the disease modifying therapies are pretty necessary. We know that now. We used to think 30 years ago when our first disease modifying therapy came on the market that they weren't going to help you to get better at all, but they might keep you from getting worse. I personally found that once I had been on a disease modifying therapy for a while, my symptoms did get better. So, yes, go on a disease modifying therapy. And this is a conversation to have with your doctor. If you're seeing a general neurologist, they're probably going to put you on something that is older and maybe less effective. If you're being treated in an MS clinic, you'll probably be going on to a higher efficacy therapy that is often given via infusion rather than injection or pill. So again, that's a conversation to have with your doctor. Judy says, does Truxima have similar results for PPMS? It may have, but Truxima is not approved for primary progressive MS. The only one of the B cell therapies that is currently approved for primary progressive is OKRIS. Let's see. An anonymous attendee says, what, if any, benefits can weight loss surgery provide to MS and its symptoms? You may find that as you lose weight, a number of things happen. You have more energy, you're able to move more, you're able to get more muscle tone. So you may be adding to physical strength. You may be able to walk further. You may find that you're able to do more, your function gets better over time. The problem with weight loss surgery is that you really have to modify your eating habits for the remainder of your life. Very, very small portions, sometimes only a tablespoon at a time of something to eat. So that means that you're really at high risk for malnutrition, and you're going to have to be taking more supplements. And a lot of the supplements that are given often have immune boosting properties, and you don't want to boost the immune system with multiple sclerosis, because if you do, it's going to make your MS worse. Sorry, I'm just clicking off some things here, get it out of the cleaning up my desktop. An anonymous attendee said, could a dietitian be beneficial for someone with MS or not necessary if you eat reasonably? A dietitian certainly could help. I know that I was thinking for the longest time as a nurse that I knew how to eat reasonably. And a lot of the things that I was doing, I found were not reasonable and they weren't helpful. Portion control was a huge thing for me. And since I saw a dietitian and really better understood what my caloric needs were energy wise, and really the size of my stomach, our stomachs are about the size of our fist. So you don't want to eat a meal that's bigger than what your fist is, sum total. And I never knew that. I just figured if I was eating lots of fresh fruits and vegetables, salads, minimizing my starches, my pastas, my breads, things like that, I was okay. And that was not the case. So I would recommend seeing a dietitian. Let's see. Paula says, is the lymphatic system or fatty tissue extra sensitive for MS persons? Since knee replacement surgery, having large bubbles of spasms on the back of both legs, they move and feel like they pop when hard pressed. No, that is directly related to your knee surgery. So you need to be working with your physical therapy team on that particular symptom. It's not MS related. It is related to the work that's been done around the knee, which impacts the lymphatic system, the circulatory system, the muscles, all of that, the redistribution of fat in your leg. So do work with your physical therapist about that. All right. Mike says, being summertime, I like to have a couple of drinks once in a while. What's the harm? There is no harm in having a drink or two once in a while. That's once in a while, not daily. Um, and never more than two, I would say, because what it's going to do is it's going to impact your balance, it'll impact your cognition. Um, and those things you really don't want to do. Um, so yeah, an occasional beer in the summertime is perfect. It'll help cool you off and maybe give you a few added nutrients. An anonymous attendee says, what do you know about the psionic neural sleeve and which symptoms does it help with, and is it worth the money? The psionic neural sleeve is it's a full leg encasement that has electrodes placed inside of it. You program it into your cell phone with specific settings that have been given to you for this. It's made out of neoprene, which is the same material that a wetsuit is made out of. So my only concern for that is if you're particularly heat sensitive, especially this time of year, it may be overheating you. The psionic nerve sleeve treats basically foot drop. It also helps if you have muscle fatigue due to your nerves kind of kicking out as you're walking, and it will stimulate those muscles to keep moving. Um, Several people tried it this last year at the Consortium of MS Centers annual meeting in Nashville. Psionics booth was just a couple of booths down from the Multiple Sclerosis Foundation booth, and people were continually walking by us holding their cell phones in their hands with the psionic nerve sleeve on. People said it felt really weird, said it felt awesome, said it tickled. But after they wore it around the room for about 20 minutes and turned it back in, they would come back by the booth and say, oh, I got to get one of those. It made such a difference. Excuse me. Is it worth the money? For some people, it is. Another anonymous attendee said, do older people over 65 tend to have more side effects with the higher efficacy disease modifying therapies than younger people? I would say older. Um, I'll be 72 in a couple of months. And I was on for 10 years. I was on Rituxan. My last dose of Rituxan was about 14 months ago. And I have to say, it's the easiest medication I've ever taken. No negative side effects whatsoever, other than maybe one or two urinary tract infections a year. The other thing with that category of drugs is that you may not mount a good vaccine response. So, for things like your routine vaccines for pneumonia, COVID, flu, um, RSV, shingles, things like that, you may not mount a good response to the vaccine. So you're at greater risk for some of those infections and need to take other precautions. Paula. Hi, Paula. Hi, Cherie. I'm 56 years old and have had MS for 20 years. I haven't been on any DMT for 3 years due to side effects. The best DMT I ever had is Tysabri, and I'm thinking about going back on Tysabri every 6 weeks as an exit strategy. Have you heard of this? I'm JVC negative. Thank you. Paula, I would recommend if you're going to do that, that you probably go on Tysabri at an every 4 week if you're still JCV negative. And then over time, And 56 is really too young at this point to consider an exit strategy. Historically, the most disease progression in our lifetime with MS happens during the fifth decade of life. So I think thinking about going off in your 50s is probably not a good idea. Um, I really don't recommend that people start thinking about going off of their medications if they've been stable until they're 60. And then only if they've been completely stable for 5 years. The other thing that, and I think Paula, you and I have talked about this before, is that Mavenclad is another drug that you might want to consider for an exit strategy. But I still think you may be too young to do that. In his talk on Tuesday, Dr. Ben Thrower talked a little bit about exit strategy medications. And he said that a lot of people that are younger, we usually see 10 to 15 years of disease stability, at least in Mavenclad. And so what happens, he asks, if you take the Mavenclad when you're in your 20s or your 30s? What happens when you're in your 40s? Do we dose you with Mavenclad again, or do we put you on another disease modifying therapy? Um, I have started the Mavenclad routine myself, so I've had my first 2 rounds of Mavenclad, and I will have my final 2 rounds in the spring of 2025. I had no side effects whatsoever with that first round, so um, feel free to give me a buzz and we can talk about this if you want to, Paula. I think you have my contact information. Um, Anybody else that wishes to call me, feel free to contact the MS Foundation at 888-673-6287, and my extension is 125. Or you can email me at Cherie, that's Cherie, at msfocus.org. Let's see, 2 new messages in chat. Louis from Facebook asks, is it normal to start to feel more fatigued the last month before your infusion, but not have any progression or active lesions? This has been my experience for a few years, and I always think I'm having a flare, but my MRIs come up fine. Louis, that is what we call lovingly the crap gap. It happens more with if you're on a set 6-month schedule with drugs like OKRIS or Briumvi, um, you might want to consider switching to something like Rituxan, which has a far more flexible dosing schedule. So I know that for a while when I was experiencing that crap gap, my neurologist did my infusions every 5 months or every 4 months instead of every 6 months. Also, there have been some studies done that look very good, came out of Spain about 6 or 7 years ago, that we may not need the full dose, the full gram of Rituxan, and they were looking specifically at Rituxan every 6 months, that people who've been on Rituxan for a couple of years often do very well with half the dose every 6 months. So talking to your doctor about adjusting the dosage or the frequency may be helpful. And Rituxan is the one drug where you've got the greatest flexibility. It's identical to Ocrevus or very, very similar to Truxima. Um, the other thing that Dr. Boster has suggested is that sometimes your doctor will have some doses of oh gosh, I'm drawing a blank now. It's the once a month Kesimpta, the once a month injection in their office, and they might give you a dose of that in the office to tide you over. Mike says, speaking of COVID, Are there any studies related to the COVID shot and MS? Timing really seems close when I got shot and diagnosed. I know that there are a lot of theories out there. When COVID first started, we recommended that you wait until just before your next dose of your B cell depletion medication. And this was really the only type of disease modifying therapy that we were giving warnings on this. Just because you're depleted for so long, they wanted to give you the best chance at, excuse me, at mounting that good response. We now know that it really doesn't make any difference because once you've been on that medication every 6 months for a year, year and a half, you're not dropping your B cells. So it really is not dose dependent. So we were giving that advice before and we're not anymore. All right, Bhavya has also put the phone number into the chat number. If you're needing to reach out to me, it's 888-673-6287, and I'm extension 125. And my email is cherie@msfocus.org. Doris said, unfortunately, OKRIS is the only drug for primary progressive MS. That's right. Stephanie asks, are lab tests done before OKRIS? My new doctor isn't doing them. Dr. Thrower addressed that on Tuesday this week as well. He said that, yes, he does lab work while they've got the person in to do their infusion. So as you're getting hooked up to do your infusion, they'll draw your bloods prior to the infusion, and they usually they do a CBC with differential. They may do a comprehensive metabolic panel. They will often do IgG levels or immune globulin levels, and they will generally do a lymphocyte subset. So they're looking to see if your CD19 cells are depleted or if they're beginning to regenerate. So those are the things that they look for. And yes, it's not really responsible medicine not to get those labs on a regular basis. Joy from Facebook asks, I have PPMS. How common is it to have bowel issues such as a sluggish colon? Extremely common. And most of that is related to fluid intake and lack of fluid intake and lack of sufficient fiber intake. So you're going to want to increase your fluid intake, and you probably will need to add something like benefiber or Metamucil if you're not getting enough fiber in your diet, which most of us actually don't. Kareem says, newly diagnosed, haven't started on any treatments yet. Is it easy to switch between disease modifying therapies? Generally, but you don't want to be switching between disease modifying therapies without giving them at least a 6-month trial. So you don't want to be popping from one medication to the other, and you probably won't find a doctor that will do that either unless there are really adverse side effects that can't be managed in other ways. An anonymous attendee says, how different are OKRIS and Kesimpta? Does one work better than the other for most people? We really haven't done them in a head-to-head trial where we've had one group of people taking OKRIS and another taking Kesimpta, looking at the response. The lab work seems to be very, very similar between the two. People tend to have very, very similar disease courses after getting started on either one of them. So Kesimpta is much newer than OKRIS, so we don't have as many years to look at as far as safety or efficacy, but it seems like the two are very, very similar in outcomes. Another anonymous attendee says, best ways to deal with pain in knees and legs, physical therapy. Physical therapy is not just making you exercise. Physical therapy has all kinds of pain relief modalities, whether it's electronic stimulation or ultrasound or infrared treatments, any number of things like that that can knock the pain down. The other thing that can help with leg pain, particularly Charlie horse type leg pain, is adding an extra 1 or 2 glasses of liquid a day. Most 90% of leg spasms are related not to MS, but to dehydration. So add some extra water to that. Fred says, I was recently diagnosed in March of 2024 and have my second, um, apparently stopped typing after that. What are your thoughts regarding the medication Ampura for walking? Fred also asks. Ampura works for about 40% of people that take it. And if you take it for 3 weeks and have not noticed any difference, you're not in that 40%. It does kick in fairly quickly, and you should be noticing a difference after 2.5 to 3 weeks at the outside. So. Maria says, my husband has PPMS and is not a candidate for OKRIS. Any suggestions? He suffers from fatigue, walking difficulties. He's on Ampura, bowel and bladder issues, and depression. I'm curious, Maria, as to why he's not a candidate for OKRIS. That's the only medicine that's approved to help with that. The bowel and bladder issues, there are bowel, bladder, and pelvic floor therapists that are out there, and it might be helpful for him to see one and get some tips on how to manage those. Depression is something that he's just probably going to have to talk with your family doctor about and maybe try a number of different techniques, whether it's medication, whether it's talk therapy, whether it's group therapy, a support group of some sort. Oftentimes, depression is really tightly tied to feeling lonely, feeling shut away from the world. So those things might be helpful. Let's see. Kareem, I got that one. Okay, it looks like I've got everything in the chat. An anonymous attendee says, I went off Copaxone at 54, almost 5 years ago. MRI is fine, but I am doing a lot of physical therapy. Okay, that sounds like an update rather than a question, but good for you. I'm glad to hear that everything is going well. An anonymous attendee says, my question is my back pain is my biggest issue. I'm almost ready for surgery. What should I do? There's too many vagaries in that question. As far as almost ready for surgery, meaning you've got the surgery scheduled and it's just about ready to come up, uh, or you need to see a neurosurgeon about having back surgery. If you don't have back surgery already scheduled, I'd make an appointment with a neurosurgeon for an evaluation to see what can be done. Usually they will not do back surgery until they've sent you to a pain clinic for nerve blocks or injections to kind of cut down on that. So there is a whole protocol regarding this, and I would get into that pipeline and start getting some treatment and some answers as far as that's concerned. Anonymous attendee is asking, is Rituxan approved by the FDA for MS? Not specifically for MS. Once it was approved by the FDA for um, rheumatoid arthritis and for lupus, it was already in clinical trials and doing wonderfully for MS at that time. The clinical trials were dropped because it was approved and could be given off-label. And we've been giving Rituxan off-label for about 20 years now for MS, and it's got probably a larger market share even than OKRIS does because it's half the cost of OKRIS. So, and they're made in the same factory and sold by the same company. The two drugs are identical, except Rituxan has the older mouse model of the monoclonal antibody, and OKRIS has a humanized model of the monoclonal antibody. So yes, it is available to use for MS. An anonymous attendee says, regarding OKRIS, what does it mean if your CD19 are depleted or regenerating? All right, so OKRIS and drugs similar to it, like Truxima, Rituxan, Kesimpta, target the CD19 lymphocyte and knock down its production. Now, it's only one of about 60 or 70 of that type or of our lymphocytes, of that type of lymphocyte. So when we knock that one out, that seems to be the one that targets the inflammation in the central nervous system. So after your second dose, you're probably going to see that CD19 go down to 0, and that's where we want to keep it. When it starts regenerating, that may mean that you need to get another dose of your OKRIS or your B cell depletion medication to bring it back down. Or it could be that you become resistant to that medication and may need to be thinking about other treatment forms. Again, Dr. Thrower does address this in his talk that he gave on Tuesday, and that is on our Facebook pages right now if you want to go in and look at his Ask the MS Expert from the 12th of June. 12th of June, sorry, July. No, his was the 9th. Sorry, the 9th of July. Today's the 12th of July. Um, and just hear what he has to say about that. The other thing that about your B cells regenerating, what we're seeing now is when people have been on this type of medication for as little as a couple of years, when they come off and those cells start to regenerate, they're regenerating as normal B cells and not the B cells that angrily attack the T cells and cause the inflammation and the flares. So one of the things that they were cautiously optimistic about at the consortium of MS Centers annual meeting in May of this year was that we may have a functional cure using these medications. Um, Keeping a person on them for a few years and then taking them off and having their B cells regenerate as normal B cells. So they're no longer triggering the inflammatory responses that are causing flares. Let's, I think somebody is up here. Hold on. Let me just. Maria says, hi, Cherie. Just to follow up on your question, my husband's doctor at Johns Hopkins said he is not a candidate for OKRIS because of his past stroke. He was also denied admittance to a ketamine for fatigue study because of his past stroke as well. Thanks. Strokes certainly can keep us from being candidates for clinical trials or for other medications. And again, it's lifestyle changes. It's going to be physical therapy. It's going to be really getting the sugars out of the diet, good hydration, good fiber in the diet, those sorts of things. Cindy says pain management is what I'll look into next and not back surgery. Thank you. Okay, so all right. Sarah from Facebook asks, how can you cope with having long COVID along with MS and taking Mavenclad? It's really hard. My last COVID infection, I got long COVID. And after 8 months of the long COVID symptoms, the cognitive stuff, the extreme fatigue, the chronic productive cough, just not feeling well at all. My neurologist started me on monthly infusions of IVIG, which is intravenous immunoglobulin. Intravenous immunoglobulin is an infusion that takes 3 to 4 hours to do, but it infuses what they do is for blood donors, they spin out some of the antibodies in a number of different blood donors so that you get uh, an infusion of antibodies from approximately 150 different blood donors. It's a blood product, but it's not getting a blood transfusion. And I actually, because of all the years I was on Rituxan, was not developing even after 8 COVID vaccines and after 3 COVID infections, I still didn't have any COVID antibodies in my blood, but the IVIG has now given me some COVID antibodies. So that may be something you might want to talk to your doctor about, Sarah. David from Facebook asks, I'm thinking about trying OKRIS. I'm 67 and found out 3 weeks ago I have MS. Is that a good choice? Side effects scare me a lot. I don't think you'll find that there are any side effects from OKRIS. The side effects may be from the steroids that you're going to get to kind of manage side effects. 67, unless you have active lesions, maybe your doctors will talk about something other than OKRIS unless they feel that it's primary progressive MS. But again, I think you're not going to find the side effects or anything to be afraid of. An anonymous attendee says, is there a certain amount of time needed between DMTs to flush out the system? It depends on the DMT. If you're taking something like Tysabri, you're probably going to want to, if you're switching DMTs, to get on to the next DMT as soon as possible, because with Tysabri and also with Gilenya, if you wait a longer period of time, you're more likely to relapse while you're getting onto another drug. So that those two classes of drugs, the S1Ps, things like Gilenya, Mayzent, those types of drugs, you may want to get onto something quickly. Same with Tysabri. If you're switching DMTs from one of the B cell depletion medications to something else, you can take your time starting something else. The washout period also, if you're on teriflunomide, that takes a period of time to get out of your system unless you do a rapid washout, which is another medication regimen with that particular drug. So again, it depends entirely on the class of disease modifying therapy that you've been on. But your doctor can tell you more about that based upon what you're currently taking. An anonymous attendee asks how long to allow for side effects to turn around for a new disease modifying therapy. The one disease modifying therapy, in my experience, that the side effects just were worse with every dose that I took was Tecfidera. I just could not get past the flushing and the GI upset. I stayed with it for 6 weeks, and there wasn't one day that I was on it that I felt healthy or that I felt good. I just felt sick the whole time, and nearly ended up in the hospital 3 times. The flushing was so bad. So if that's happening to you, then you need to call your doctor and get off of the medication and onto something else. Generally, the rule of thumb is that you don't want to switch until you have given the medication at least 6 months. So the 6 months is probably the answer you were looking for. An anonymous attendee said, I just had my thoracic spine MRI and I felt very nauseous after the contrast injection. I have my brain MRI next week, also with contrast. Is this a normal side effect? It can be, and it's generally worse if you're dehydrated. So I know a lot of times before we get into the MRI machine, we limit our fluid intake so we don't have to get up and go to the bathroom. But you really do need to hydrate very well, heavily, before you go in for your MRI, and then hit the bathroom before you get down onto the MRI bed. That should get you through just fine. Mike says, I'm 67 and I want to start a DMT. I'm secondary progressive MS. I did the ABC drugs 25 years ago. Okay, if you're secondary progressive MS, Mayzent is the one drug that we have right now that is specifically for secondary progressive MS, and it's a daily pill. Okay. An anonymous attendee says, where can I get help for a DMT cost if I'm on Medicare? That's one of the reasons I ended up on Rituxan, because Medicare will cover what's given in an infusion center, but they don't cover anything that is given by yourself. So none of the injections, none of the pills. The drug companies can't help us, but there are several foundations out there that can, if you're below a certain income level, and it's a very generous income level. I think it was uh, $75,000 a year for the individual, and $150,000 a year if you're married. Um, they would be able to help with the copay or even erase the copay altogether. However, the MS meds only come up once or twice a year, and your Medicare year starts on January 1st, and the foundation monies don't come out until I think May or June. They say they'll approve you for a year, but by the time you get back to January, you've got to reapply again and the monies aren't there. So my my experience is that it's not consistent and there's a lot of out of pocket money. So you may want to talk to your doctor about getting on something that's given in an infusion center, whether it's Tysabri or whether it's Briumvi, OKIRIS, Rituxan, Truxima, one of those medications. Alyssa says, if a person has already had a round of Mavenclad 5 years ago, can they go on another round? This person is over 60. Um, we have very, very few people that have had to do a second round of Mavenclad. Generally, if it's working for you, it's going to work for 10 or 15 years. So you may want to consider doing something else, but that's a conversation to have with your doctor and figure out what they'd like to try and see. Um, if you're over 60, it could just be that you're not having active disease, but that you're having progression and you may not actually need another disease modifying therapy. Stephanie says, is nausea a common symptom? I get nausea frequently when I'm fatigued. Nausea is also a common symptom for dehydration. And fatigue is a major side effect of dehydration. So, this time of year, particularly when the heat is so bad, you need to be really drinking consciously. Fred says, I was recently diagnosed in March of 24 with, he says RSMS. I think it would be RRMS, relapsing remitting multiple sclerosis, at the age of 57. In your experience, how unusual is this? Most information I've read states most diagnosis occurs between the ages of 20 and 40. Thank you. We used to think that that was the standard age for diagnosis. However, there's a lot of information coming out to those of us in the healthcare professional arena right now, stating that we seem to be having a flurry of late onset MS diagnoses after the age of 55, some even into their 70s. So it's not unusual. It could have just been missed all these years. And it could be that it's something related to MS, also like neuromyelitis optica, that is causing these symptoms at this age, because that can happen later on in life. Mike V, okay, I already answered Mike's question because he put it into both the chat and the Q&A. An anonymous attendee says, what to do for diarrhea on a DMT for several months? Does it usually get better the longer you're on the DMT? I can't think of any DMT that would cause diarrhea other than possibly Tecfidera. And again, that should resolve over a period of 2 to 3 months if it is caused by the DMT. So I would have a conversation with your doctor about that and maybe consider switching the DMT as a result of that. An anonymous attendee says, my wife is recently diagnosed and started Tecfidera in the last 3 weeks. This is causing GI problems as well as feeling sluggish and regular vomiting. Is this normal in adapting to this drug? It absolutely is. this is probably the one drug that has this as a major side effect, and some people just can't tolerate it. Um, Sometimes taking an aspirin beforehand can help to diminish with the flushing, but it doesn't help the GI symptoms. I would not take something like Tums with it because it can deactivate the medication. So taking it with a high fat meal can often relieve some of those symptoms. So um, unless your wife is a vegan, she might enjoy a breakfast of bacon and eggs, and that should help when she's taking her Tecfidera in the morning. So I would see if those dietary changes don't help, and if they don't, then certainly talk to the doctor about switching the disease modifying therapy. Katie from Facebook asks, I'm new. I am a new diagnosis and I'm on Tysabri. I just had my third infusion at 38. I still have a lot of head pain. What could help and what vitamins should I take? The head pain, is your doctor aware of that? Are they headaches? And has your doctor worked with you on a headache regimen? Um, is it being relieved by something like aspirin or Tylenol or ibuprofen? As far as vitamins, most people with MS should be taking vitamin D. B12 supplements might be helpful, but other vitamins, as a rule, no. In fact, they just came out 3 weeks ago. There was an article in MedPage today that vitamins, a daily multivitamin, has been shown not to prevent heart disease or strokes, and that there seems to be no across the board health benefit from taking a daily vitamin. They said it doesn't generally kill you or make you worse, but there is absolutely no benefit to taking a once daily vitamin. Mike V says Mazent is not covered by Medicare. No, it is not, but you might be able to get it with a foundation grant to cover the cost of the medication. Maria says, besides baclofen, is there anything for spasticity? Do you have any suggestions or thoughts on medical marijuana for MS? My doctor has given me an as-needed prescription for tizanidine, which is also known as Xanaflex. Um, I don't like the side effects from baclofen. I don't like the mental fog. I don't like the sleepiness. I also feel like baclofen can make you almost rubbery as far as your muscles are concerned, so you may be more at a fall risk. So with the tizanidine, I only take it because it does have also some sleepy side effects. I usually only take it just before bed at night. It helps the spasms to relax so that I can get a more decent night's sleep. And that sleep makes a world of difference in how severe the spasticity is. As far as medical marijuana for spasticity, it has been shown to be helpful, but people tend to misuse it, particularly if they're inhaling it. You should use it like you do any inhaler that you would use for asthma or bronchitis or anything like that. A couple of puffs with some time between each puff. So you take a deep breath in and exhale a couple of times, and then on your third deep breath in, take your puff and hold it for as long as you comfortably can, and then let it go. Wait 3 to 4 minutes, do the same thing. Knock the ash off and use that same joint the next time you need your medication, which likely will be 2 to 3 hours. So use it as you would any regular medication. The other option is to use a gummy that is formulated to have a specific amount of THC in it. And again, you might want to talk to your doctor about what level of THC is best for your spasticity levels. So yes, medical marijuana could be helpful. Let's see. I have somebody in chat here. Mike. Sorry to even ask this during Zoom, but you're very knowledgeable. Does MS have sexual side effects? Please do not answer if uncomfortable. It can. Um, the nerves that feed our pelvis, so the nerves that affect your bladder, your bowels, and your sexual function, your sexual activity, all come out of the spinal cord around T11, T12. So the bottom edge of the thoracic spine going into the lumbar spine. If there are lesions in those areas, you're more likely to have problems with bowel, bladder, or sexual problems. And again, there are pelvic floor rehabilitation specialists who can help with these sorts of things. For some men, things like Cialis or Viagra can be helpful, but they tend to be more related to blood flow to the area than actual nerve flow. A lot of times, you may not feel like you're getting a normal sensation when you're sexually intimate, but stimulation by yourself or your partner can often help to get that response there, even if it doesn't feel exactly the same. So there are people out there that can help with that. And I would definitely talk to your doctor about it. An anonymous attendee says, I have secondary progressive MS. My doctor wanted me to take Mayzent, but my copay was not affordable. I'm on Medicare. So he recommended OKRIS. Will OKRIS have an effect on SPMS? I think so. I know that as I look back over my nearly 50 years now of living with MS symptoms, there have been times I know that I would have been diagnosed as secondary progressive MS, but then have gotten onto an effective disease modifying therapy that has knocked down inflammation in the central nervous system, and I've gotten back to more or less peak functioning. So it's certainly worth a try. I think I would be fine about you doing that. And again, as I said, I ended up on Rituxan because I couldn't handle the copay for the self-administered medications with Medicare. An anonymous attendee says, I read that PET scans are being used for MS. Do you know anything about this? They are not being used for MS. There are some studies very much in the early research stages looking at whether there are PET scan changes that can be seen in the central nervous system. And there are some things that it looks like we can see more clearly with a PET scan than with an MRI, but it is not used in practice at this point. Mike says, what else can you do to combat progression besides meds? Exercise is one of the best ways to combat disease progression. Progression tends to make us want to slow down. And as we slow down, our MS feels like it's getting worse because we're actually getting deconditioned, and we don't, the more active we are, the better condition we stay in. So exercise is very helpful. Again, cutting out sugar in our diets. Going for a daily walk, if you can do that, getting out into some sort of nature, even, and if you don't have anything like that near you, if you live in a concrete jungle, then find some way virtually to get into nature. Those things can all help with disease progression, but exercise is a real big one where that's concerned. All right. Will this be recorded and sent out for later viewing? This is being recorded. It is also on Facebook Live right now, and I will be posting this recording in our private Facebook pages as well after the session is over. Within a week or so, it's going to be on the Multiple Sclerosis Foundation YouTube channel. An anonymous attendee says, have you heard of taking cholesterol for diarrhea while on a DMT? No, but if that's what you would normally take for diarrhea, then you should be able to take it while on a disease-modifying therapy. I don't think there's any contraindication to taking a symptom management medication like that. And another anonymous attendee says, what is gabapentin used for in MS? It's generally used for nerve pain. Some doctors will tell you it's for spasticity, but it's really used to manage nerve pain. And it doesn't always work. There are a lot of people for whom gabapentin doesn't work, and they keep going to higher and higher doses, and it can have some pretty intense side effects. I was at, I think, 600 milligrams or 800 milligrams 3 times a day at one point, and I didn't feel that my pain was at all relieved. I felt cognitively really impacted by the drug. I was sleeping all the time, and in just 2 months, I put on 25 pounds with the gabapentin. So if it's not helping the nerve pain, literally within a few doses of it, I would reassess whether or not that's a drug you want to be on. Anonymous attendee says, I've tried venlafaxine and bupropion for depression related to my relapsing remitting MS. Is there a recommended or commonly prescribed MS antidepressant? There's not. And antidepressants aren't a perfect medicine. It's usually a trial and error sort of thing, but the problem with antidepressants is that they usually take 6 to 8 weeks to get to a therapeutic level in your bloodstream. And when you're starting them for depression, sometimes you feel like you don't have 6 or 8 weeks to hang in there. So talk to your prescriber about that. Set up some sort of a check-in system so that you've set a safety net into place, and you don't get discouraged, and even mark on your calendar week 1, week 2, week 3, so you're getting closer to potentially seeing some relief. But it's going to take 6 or 8 weeks on any antidepressant before you really see full therapeutic value. Katie asked as a follow-up on Facebook, what are the best foods and how much water should I consume? The recommendation used to be 8 ounces of water, or eight 8 ounce glasses of water a day, but our bodies are very different. So what they're now recommending is to take your weight, divide it by 2, and aim for that many ounces of water a day. So if you weigh 150 pounds, that divided by 2 is 75. So you should aim for 75 ounces of water a day, which is about 3 liters. So we're getting close to the end here. Is it common to be stiff? I can bend my knees, but feel very stiff in my pelvic area and legs, even though I stretch 3 times a day. It might be helpful for you to get a physical therapy evaluation. It could be that the way that you're stretching is not an effective way, and a physical therapist could show you how to get more effect with maybe less energy at it. So stiffness is often related to spasticity. And so I would recommend a physical therapy evaluation. Paula says, is clemestine, aka Tavist B, being used, or was it relabeled for MS? There are still some clinical trials using clemestine, and it's basically being used for nerve repair or remyelination. Still nothing really positive coming out of that. It's too early, and we do not recommend you take Tavist D as a nerve repair thing at the moment, because we don't know if that's working. It showed hope in laboratory animals, but not yet in humans. Have you heard Cymbalta can cause fatigue? Absolutely. Are there any meds you can take for a neurogenic bowel issue besides digital stimulation? Not that I'm aware of, but again, things like if it's neurogenic bowel that's causing stool incontinence or liquid stool, then you may very well need to be bulking it up with some Metamucil or Benefiber. We are a little after 4. I'm just going to try to just pop in only maybe a couple more questions, and then we'll end this. Speaking of exercise, I found the MS Gym on Instagram very helpful. Mostly free videos, but can expand to a minimal pay structure. We know all about Trevor Wicken. He has been a champion of the MS community for nearly a decade now, and many of us here have attended the MS Gym, but thank you for bringing that up. Is there a pill for spasticity, or is exercise better? Exercise is always better. We want not to treat with pills if we can treat more naturally on symptom management. However, we do need you to be on a disease modifying therapy. Fred says, oops, sorry, that just popped out of my range as somebody else popped in. Oh, you're welcome, Fred. All righty, folks. Thank you so very much. This has been a busy, lively webinar. Our next webinar will be next Tuesday, July 16th at 6 p.m. Eastern Time, and it will be the Black MS Experience, where we have a panel of 5 Black women who will be sharing their experiences with MS. This is the first in a series of several webinars of experienced persons with in different groups. And so you'll be seeing probably another Black MS experience in 3 or 4 months. We welcome you to come and sign up and come and join us for that. Thank you, and please stay on the line for just a few minutes, or just not a few minutes, just a few seconds after the Zoom ends for a brief survey about what you'd like to see offered in the future for our webinars. Thank you all. Have a good week. Stay cool.